Good afternoon. I'd like to welcome everybody to the session Rapid Fire, Top 9 Corneal Topics You Must Know. On behalf of the Corneal Society, we'd like to thank the European Society of Ophthalmology for inviting us to put on this symposium for you. We have 9 great topics that range everything from dry eyes to the future of endothelial cell replacement therapy that everybody really should know about. And so what we're going to do is we're going to go through all of the speakers, and then we'll take questions at the very end because it's going to be a very rapid pace here. And so without further ado, I'll ask our first speaker, Dr. Stephen Kaufmann from the United States, to give the first talk on new drugs and gadgets for dry eyes. Do they work?
Thank you very much, Bennie, and it's a pleasure to address you. We'll go through some topics. My initial, let me go through this first. I have no conflicts of interest, and I did this research with John Conto, this paper also, and he has no conflicts of interest either. But one thing I just want to emphasize, it was emphasized earlier in the session this morning on dry eyes, that you really have to identify the cause of the dry eye, and you address your treatment to that. And whether it's exposure or an aqueous deficiency or a mixture of both, you have to address those, or whatever treatment you pick will not work long term. I'm going to skip over this. This initial portion of the talk was on oxervate, but Dr. Colby will be addressing that in much more detail. And the only thing I'll say is that the initial paper that I saw on this was in the New England Journal of Medicine. It's published in 1998 by this group in Italy, different institutions, and probably the best part of this paper, which was a great paper in a very prestigious journal, is at the end, after the title and after the authors and after their academic institutions, it said all in Italy. So that was fantastic. So let's talk a little bit about meibomian gland disease. It is helpful if you have a if you are able to perform meibomiography, and you can see the dropout in the meibomian glands in this area. You can see that the glands are thickened also, perhaps. This is normal, and the glands, as you know, are on the upper lid and the lower lid, so this disease can occur on both lids. And this has been addressed in a few different ways. A device which has been available for quite some time is the LipiFlow device, and this is just an example of how it works. It applies pressure to the meibomian glands, and it also has a heating element externally, but also a heating element on the internal aspect of the eyelid, where it applies pressure. And this is really to help liquefy the oil in the glands that may be thickened, and then also to express that oil. As some of you may know, that device is relatively expensive, particularly here in Europe where I spoke to some people, and there are some limitations. So other devices that are new are becoming available, and this is one called iLux. iLux is a handheld device. It's much less expensive, and it is a device, though, that is primarily manual. So this device is placed with a little portion that fits under the lids, and you manually apply pressure as heating elements against the eye, and also externally heat the oil, and so this can provide the same type of treatment. There's another device that just applies heat without any pressure, and this is called a TearCare, and this device has a little external unit with a thermocoupler and applies heat through these pads on the eyelids. All these devices are FDA approved. They have all been shown to improve ocular surface disease index scores, but there are no large-scale studies. There are no comparative studies from one to the other against other devices or other treatments. Meibomianography can be useful. You can check to see if the meibomian glands are coming back. But in some of these cases, you may not see a lot of improvement in the meibomian glands, but the patients will be symptomatically better. So don't be discouraged if you don't see an improvement of the glands, because the patients will feel better, and that's a good indication that the treatment was effective. These usually have to be repeated. This is not a one-time treatment. There's also manual expression of the glands, and there are no comparative studies to tell if this basic treatment is any more effective than these newer treatments. But again, you have to treat the underlying cause. There are some devices that were discussed earlier today by Dr. Carlos Verges, and he discussed Therma eye devices. And there are a few different devices, and these are radiofrequency, conductive, and resistive forms that are able to warm the tissue and help liquefy the oil in the glands, and also pulse light technology too. His presentation is available online through the SOE website. I encourage you to look at that. There's a tremendous amount of information, but none of these are available in the United States yet, the newer devices. Demodex is really an unrecognized, in many patients, underlying cause of meibomianitis. And it is important to treat that. Claridex has been available in the United States for quite some time. It's a tea tree oil. And there are now new alternatives to that because that used to be the only formulation. These newer derivatives of tea tree oil are not yet tested, but in comparative tests, but they are a little bit less expensive. And this is something that's available in the United States, non-prescription. I assume it's available here also, specifically to treat Demodex of the lids. There are many different artificial teardrop formulations also. These different teardrops, there are many aqueous new drops, differences from one to another a little bit, but now there are also many more drops that treat deficiencies of the oil or lipid layer that are important. Some use little oil micelles, and others that can be important, particularly but you need to diagnose the fact that these patients are missing the lipid layer of their tear film. There are also newer drops too that are said to replace the mucin layers too, or fortify the mucin layer of the tears. Along those same lines, there are also artificial teardrops that provide vitamin A and or omega-3 fatty acids that are said to decrease inflammation and perhaps increase the health of the surface of the eye. These are available here, but again, these are over-the-counter and do not require a prescription, and I have not seen any large trial for any of these in any comparative studies. There's some newer eye drops that will be available soon, I think in the next year or two, and these are actually drops with formulated amniotic membrane. Amniotic membrane in the United States can be used to treat a keratitis or a dry eye, and it's FDA approved for that. But what these companies have done have either distilled the components of the amniotic membrane, or they've essentially, what they say, morselized, which is essentially mincing amniotic membrane, placing it in a viscous eye drop, and that is said to be effective also. We did some of the original work with Regenisol for biotissue and formulated that. The newest of all the devices, though, which is available in the United States and very interesting, works in a different principle. It's called TruTear. It's sold through Allergan, and TruTear is a neurostimulator with a hydrogel overlying a little electric pad. And this device provides stimulation to the nasal nerves, and it increases tearing through a central pathway. This is an example of how it's used. It's placed all the way in the nose and then tilted backwards, and the positioning is critical. And this shows that the patient does have some tearing from that. At the recent Patent Society luncheon, which we just had a week ago at the EBAA meeting, we talked to people about their uses and patient use of it, and it is efficacious. However, some patients stopped it. It's a little bit expensive. You have to buy these disposable tips, but it is easy to use. It does stimulate the primary lacrimal gland, and that's a question of whether the tears formed by the primary lacrimal gland are different than the tears formed in the accessory lacrimal glands, and I think they probably are. So long-term studies still need to be done with this device, but it does produce tears, and patients do have an increased Schirmer score with this, and I'll show you the data in just a moment. This is generally used for 1 minute. There are 6 different energy settings for it, and you're not supposed to use it more than 30 minutes a day, so you can use it generally anywhere from twice a day to about 10 times a day. This is the initial FDA study, and the initial FDA study only tested a single treatment, but all the patients in the study had less than 10 millimeters of a Schirmer score, and you can see that after the treatment, they had a score of 25 on the Schirmer. A sham treatment where they stuck the device in their nose, but there was no electrical stimulation, did not show any improvement, and using it extranasally with an electrical stimulation did not provide any extra tearing either. In a larger study that was conducted over 6 months, you can see the results. This red line shows increased tear production, which maintained over 6 months. There was a little tachyphylaxis, but the control group had no improvement in Schirmer scores, and it remained at 10 in the 6-month trial. There are complications, as always, and some of those were nosebleeds and a little bit of discomfort. We tried it in our clinic, and it really was not too uncomfortable. There's kind of a little buzzing sensation. But generally in these studies, again, there's a lack of a large comparative study. The question of whether the tears are the same when they come from the primary gland versus the accessory, and there's a lack of long-term results, and there are some adverse effects. So basically, there are many new devices, many new drugs. You should review those, make sure you know what they are, look for them in the future. We are waiting for bigger studies and comparative studies, and we want to correct the underlying cause of the disease, and it has to be treated correctly or you will not have success. Thank you very much.
So we'll invite up Kathryn Colby from the United States to talk to us about the nerve of you, new ways to treat neurotrophic keratitis.
Good afternoon, everyone. It's a pleasure to be here, and I want to thank the organizers for putting together this great symposium. I have no financial interest in the topic of this presentation. So I'll begin with a case report. This is a healthy 16-year-old girl. She was followed by an outside ophthalmologist for unilateral Tygason's disease without success for 1 year. She was then seen by one of my colleagues, a very savvy pediatric neuro-ophthalmologist, who tested her corneal sensation and found it to be absent, causing an MRI to be done, which revealed a low-grade meningioma. We'll come back to her in a few minutes. Here's her initial picture of what she looked like, the other eye being completely normal, and that was the clue that something besides Tygason's disease was going on. Now, the first important tip in managing neurotrophic keratitis is to actually make the diagnosis, and this case illustrates this. It's a degenerative condition that results from impaired trigeminal innervation caused by a diverse group of conditions. It can be either congenital or more commonly acquired, and herpetic keratitis, either zoster or simplex, is a common cause of neurotrophic disease. So I put this list here not to have you memorize it, but just for you to realize that there are multiple different diagnoses that cause this disease, and there are multiple ways to actually make the diagnosis, various ways to measure corneal sensation, and of course we can always use our advanced imaging technology to see a lack of the subbasilar nerve plexus. You also need to understand the pathophysiology to understand its treatment and effect on the ocular surface. And basically, the impairment of innervation causes metabolic and morphologic changes in the corneal epithelium and perturbations in the very complicated milieu that is the ocular surface. Also understand disease progression. Early on, you're just going to see a little bit of epithelial irregularity and punctate keratopathy. In an intermediate stage, you typically have an epithelial defect with rolled edges, as shown here, stained with rose bengal. And then further on in the disease, you'll have progressive stromal thinning, eventually with dust metacele and corneal melt. And it really is much better to intervene prior to these stages. Now, traditional treatments are very important, and these are as simple as avoiding toxic medications, managing any concurrent disease like dry eye or exposure keratopathy, increased lubrication, again, being careful to avoid preserved medications, using punctal plugs or punctal cautery. Of course, cornea specialists, we always like to use steroids for almost everything, but these do need to be used with care if there's any stromal thinning. Serum tears can be useful, as well as systemic anticoagulantases like the doxycycline and tetracyclines. And then covering the eye with a bandage lens or scleral lens can also be helpful. So here is our patient, the 16-year-old girl with a low-grade meningioma, and we treated her with a PROS device, and you can see here that the application of that device produced a nice, normal, regular ocular surface. Other traditional treatments include tarsorrhaphy, a simple tape tarsorrhaphy, a Botox injection into the eyelid to cause ptosis, a suture tarsorrhaphy, or permanent tarsorrhaphy. Amniotic membrane can be helpful, and although we don't use these too much anymore, conjunctival flaps can be useful, of course, at the sacrifice of vision. And here's one of my Zoster patients who had a persistent epithelial defect, and that was healed with an inlay-onlay amniotic membrane transplantation. Now, the topic of my talk was novel therapies, but I will discuss now oxervate, the recombinant nerve growth factor, as well as neurotorization. But you must have in your armamentarium the traditional therapies, because although these new therapies are very appealing, they're not, they do have some significant issues with them. So as Dr. Kaufmann mentioned, oxervate has recently been approved in the US. Prior to that, it had been approved in the EU. And this is a recombinant human nerve growth factor. The study that led to FDA approval in the United States was the Reparo study, which examined stage 2 and 3 neurotrophic keratitis, and 156 patients were randomized to either placebo or one of 2 doses of the nerve growth factor, which was used 6 times daily for 8 weeks. And then there was a follow-up period of approximately 1 year. The primary endpoint was corneal healing at 4 weeks, and you can see that the placebo had about 20% healing. That is the natural course of the disease. It does get better in some patients with time. And then the 2 doses of nerve growth factor led to a much higher rate of epithelial healing of about 55 to 60%, and this was increased after 8 weeks of therapy, but the 4-week data was what was used for FDA approval. And this was published by Stefano Bennie et al. In Ophthalmology last year. Now, this does not come cheaply. The cost of it in the US is $12,000 per week for a total of about $94,000 for a course of treatment. There, of course, are other therapies in the works for neurotrophic disease, including matrix regenerating agents and other therapies, but these have not been approved yet. Finally, corneal neurotization. This is not a new therapy. This was suggested over 40 years ago, although really reports just started coming out about 10 years ago. And the initial approaches were actually quite disfiguring, requiring a large bicoronal incision. You know, cornea specialists, we don't even like to do large incisions for corneal transplant anymore, let alone doing a big forehead incision. And the idea is for a unilateral neurotrophic disease that you would take a contralateral unaffected nerve and then tunnel it under the skin of the bridge of the nose to innervate the neurotrophic cornea. And this was called direct neurotization, but required extensive dissection. Now, subsequently, innovations have been made, including the use of the sural nerve, which is harvested from the leg, as an interposition graft, meaning that you did not have to do these very large incisions to harvest the nerves. Newer approaches, including endoscopic direct nerve transfer to reduce the incision size, and most recently, use has been made of an acellular nerve allograft as a carrier for the new nerves, and thus you don't have to do the sural nerve dissection. And this is an example of the cartoon of the indirect neurotization, which again has much smaller incisions, but still this is a lot of dissection here. Now, many other nerves have been used, including the infraorbital nerve, and there have been modifications to the surgical techniques to reduce both operative time and postoperative complications. And in a thorough review of all the published literature, I could only find approximately 40 to 50 cases of various forms of neurotization published. Now, most recently, this is from a former colleague and still good friend at Mass Eye and Ear, Roberto Pineta, and one of the ENT surgeons at Mass Eye and Ear, using the great auricular nerve and a sural nerve interposition graft. And you can see here there's a very small incision, and then the The nerve graft, the sural nerve, is placed and using scleral pockets put actually into the cornea, and you have a very nice result here with, again, a small incision. Now, according to Roberto, this takes about 2.5 to 3 hours. He's a very good cornea surgeon, and I'm assuming the ENT surgeon is good. Can't think of many other things that cornea specialists do that take 2 to 3 hours. And then you can see by confocal microscopy a regeneration of the nerves, and using aesthesiometry, a measurement of intact sensation. So this is really a technique that is undergoing a lot of modifications. So in conclusion, new therapies are available, but they are currently very resource intense, whether that's dollars or euros or surgical time. Additional therapies are in development. Let's all try to prevent this. We have a very low uptake of the Zoster vaccine in the US, but this is a really important way for us to help reduce complications for our patients. You want to consider the diagnosis, and don't forget the tried and true therapies, because they really are very effective and are not as expensive or resource intense. So I'd like to invite you all, as I'm finishing, to the upcoming World Cornea Congress. This is a great meeting for cornea aficionados. It takes place every 5 years, and it will be in Boston before the ASCRS meeting next year. Thank you.
Next, we'll hear from Bennie Jeng. Does suppressive antiviral treatment prevent recurrence of herpes zoster of the anterior segment?
Thank you, Jennifer, and thank you, Kathy, for the segue right into the topic. Talking about antiviral treatment for herpes zoster. I have no financial interest, but I am co-chair of the zoster eye disease study, which is funded by the NIH, which we'll talk about in a little bit. So I'm just going to ask everybody to take half a step back for about 20 seconds to remember what shingles is. Herpes zoster, we all know, is a very, very bad disease. It's caused by reactivation of the varicella zoster virus in people who've had chickenpox. This typically results in a painful unilateral dermatomal vesicular rash. And in the US, with a population of about 350 million, 1.2 million new cases of herpes zoster occur annually. 10 to 20% of these involve the first division of the cranial nerve 5, which results in herpes zoster ophthalmicus. So a little bit of quick math will tell you that there's about 120 to 240,000 new cases of herpes zoster ophthalmicus in the US every year. That is a lot of HZO. And it's not just in the US, and so for those of you who have seen more and more zoster, it's true. The incidence of zoster worldwide has actually been increasing in the last 50 to 60 years. These are studies from all across the world, and you can see how the incidence has gone up. And in the US, for herpes zoster ophthalmicus specifically, this is a study from Mass Eye and Ear. You can see on the left side, the number of cases has gone up every year, and the age at presentation has actually gone down every year. So it's happening more often, it's happening in younger patients. Now, fortunately, we do have the zoster vaccine, which Dr. Colby alluded to. The original one, the Zostavax, was the live attenuated vaccine that was introduced in the US in 2006 for age 60 plus, and then it was then decreased to 50 plus. The problem is that the vaccination uptake in the US is actually very, very low. In 2013, it was under 25% of eligible patients being vaccinated. And in England, much better, but still only about 50%. And then if you look at the fact that it's not 100% efficacious, at 1 year it's 69% efficacious, and then the effect wanes, and although you're supposed to get a booster shot every 10 years, we think that after 8 years you almost don't have any more effect. It's down to 4% protection. Now, I think everybody's heard about the new vaccine that's come out in the last less than 2 years, the adjuvanted herpes zoster subunit vaccine. It's been shown to be effective for patients age 50 plus, as well as for patients 70 plus. And it's supposed to be much more effective than the Zostavax, 97% effective for age group of 50 to 69, and 91% effective for 70 and older, the patients who really get in trouble with this disease. In addition, it's 91% effective against postherpetic neuralgia, and it's supposed to be effective for up to 15 years. And if you look at a comparison across all the different age strata by 10 years, you'll see the adjuvant and subunit is much more efficacious than the live attenuated vaccine. So, given that the uptake is low and it's not 100% effective, and even the new vaccine is not perfect, we're still going to see this. And so, as ophthalmologists, we may not see this primarily. It may come through an emergency unit, but it's pretty established that treatment for zoster, whether it's ophthalmicus or anywhere else systemically, is oral antiviral treatment for within 72 hours of onset of rash for 1 week, with your choice of antivirals as listed here. However, the problem for us as ophthalmologists is that with herpes zoster ophthalmicus, we know that some people will get ocular manifestations. And in fact, if you look at different studies, that percentage of patients can actually be very, very high. This study from Hong Kong demonstrates that over 50% of patients who have zoster ophthalmicus actually end up with some sort of ocular manifestations. And so I'd be remiss if I didn't show you a few photos. And this is, epithelial keratitis, this pseudodendrites, and the mucus plaques. This stromal keratitis is what will get you in trouble with the vision. And then neurotrophic keratitis, which we just heard about, comes in various flavors, from the mild at the top to very severe at the bottom, even leading to perforation. And so this is a real problem, neurotrophic keratitis. To be complete, I just wanted to show you episcleritis as well as iritis that can also occur as an anterior segment manifestation of zoster ophthalmicus. So the treatment of zoster keratitis, there are different ways of treating it, but generally people agree that you can do lubrication and not do anything because of new evidence that suggests that there is live virus. Ganciclovir gel has been shown to be effective, or debridement. My approach generally is to treat them with oral antivirals, and so I'll go the route that you would do for necrotizing stromal keratitis because there's active virus replication. The treatment of stromal inflammation is way beyond the time limit that we have here today. Some dosage and variation of topical steroids are usually needed to control the stromal inflammation, but the taper is where it's problematic. It's very hard to get patients off of it, and oftentimes we need to leave them on some low maintenance. And the question comes in is there a role for oral antivirals in this picture, because this can be a very chronic course. And what do I mean by that? Chronic and recurrence that lasts longer than 90 days or shows up 90 days and after can occur. In this study from Miami VA, 25% of patients 5 years after having zoster ophthalmicus have chronic or recurrent anterior segment complications from the original inciting event. 25% at 5 years. In this particular study from Italy, 51% of patients have recurrent ocular manifestations of zoster ophthalmicus. So it's a real entity, it's a real problem. So the question is, we know from the HEAD study that you can do long-term suppressive treatment with oral acyclovir to have a 45% reduction in recurrent HSV disease at 1 year. Can we extrapolate that out for zoster, for VZV? When in 2010, the Corneal Society listserv was asked this question to Corneal members, and 100 respondents replied, and 56% of cornea specialists actually believe that prolonged oral prophylaxis could reduce recurrent signs of herpes zoster ophthalmicus. And 28% of these cornea specialists believe that the recurrences can be reduced even after stopping the course of acyclovir, so using it and there's a little bit of a lasting effect. Now, this is not actually based on any data. This is empiric data, because there really isn't any study out there. A few years later, there was this one study that came out from the Italian group looking retrospectively at 200 cases of simplex and zoster ophthalmicus, treating them with suppressive valacyclovir at a low dose, 500 milligrams once a day, or acyclovir 400 milligrams twice a day, which I would consider a simplex dosing. And in both zoster ophthalmicus and simplex patients, there was a decrease in the recurrent episodes of inflammation, almost to the point of that 45% that we saw in heads. And so this is our first suggestion that actually there might be some evidence that prolonged oral antiviral prophylaxis might be able to help with zoster as well. And so that was a genesis for Elizabeth Cohen to come up with the zoster eye disease study, which is analogous to the head study. This is a multi-center, randomized, placebo-controlled clinical trial to determine whether prolonged suppressive valacyclovir treatment reduces complications of herpes zoster ophthalmicus, including eye disease and or postherpetic neuralgia. So the primary endpoint is keratitis, epithelial, stromal, or endothelial, and iritis, the first occurrence within 12 months during the treatment. Secondary endpoints are to see if there is a lasting effect of that suppressive dose for up to 6 months after that 1 year of treatment, and also to look and see if postherpetic neuralgia is affected by the use of oral antiviral prophylaxis as well. This trial is a 5-year study. It started about 1.5 years ago in October 2017. You'll see the blue line is where we're supposed to be. The red line is where we're actually enrolling, and so we are far behind enrollment, but we have drummed up some more business with 65 active centers, including international centers, to help us accrue the 1,000 patients that we will need at the end so that we can actually answer that question. So in conclusions, herpes zoster is still a common problem, and it's increasing in incidence with younger age at presentation. There is a new vaccine with reportedly very high success rates, but we're still going to see it. And anterior segment involvement of herpes zoster is a serious condition that can cause visual loss, and it can be chronic and recurrent. And therefore, we have this clinical trial underway to determine if anterior segment manifestations of herpes zoster ophthalmicus can be reduced with prophylactic antivirals. And hopefully we'll have the answer for you soon. Thank you very much.
Next, we'll hear from Sophie Deng. Diagnostic testing for limbal stem cell deficiency, is it necessary?
I would like to thank Dr. Bennie Jeng for the kind invitation. This is my financial disclosure, but I have no financial interest of topic I am speaking on today. Limbal stem cells are a group of adult stem cells reside at the basal layer of the limbal epithelium, and they maintain the normal hemostasis of the corneal epithelium. The International Limbal Stem Cell Deficiency Working Group came to a conclusion on the consensus of the definition, classification, diagnosis, and staging of limbal stem deficiency, and the paper published last year. And limbal stem cell deficiency is defined as an ocular surface disease caused by a decrease in the population and or function of the corneal epithelial stem cells that leads to the inability to sustain a normal hemostasis of the corneal epithelium. The replacement of the corneal epithelium by the conjunctival epithelium is the hallmark of this disease. It can cause by mutation, genetic mutation, or a cell of secondary insults from a wide variety of different injury to the limbal region. The disease exhibits a wide spectrum of clinical presentation that correlates with the degree of the stem cell deficiency. In stage 1, the central cornea is spare. In stage 2, the central cornea becomes involved. And stage 3, the entire cornea is affected. So these are some of the clinical pictures of the eyes with sectoral partial stem cell deficiency. This stippling staining is pretty classic presentation, as well as this delay staining. In the, stage 2, sectoral total limbal stem cell deficiency, and the sector of the cornea is affected, including the central region. You can see that there's a thinning of the epithelium. This is not epithelial defect, but pooling. In stage 3, the entire cornea is affected. But many times, not all the patients come in with those classic presentation. For example, this patient has pretty severe opacity of the epithelium, and the staining pattern is not that, as you've seen, that show you in the previous slides. So what is the diagnosis for this patient? It is a stem cell deficiency or severe dry eye. To confirm the diagnosis of a stem cell deficiency, the gold standard had been in-person cytology that could detect the goblet cells on the cornea, shown here. But however, absence of goblet cells does not mean that there's a lack of a stem cell deficiency, and the presence of the goblet cells does not mean that there's total stem cell deficiency, because many ocular surface disease that lead to limbal stem cell deficiency also have concomitant goblet cell deficiency. And importantly, immunovascularization often was considered as a pathognomonic sign of stem cell deficiency. Actually, that's incorrect. So over the last 5-10 years, there are many advances made in the diagnosis of stem cell deficiency. They include molecular diagnostic testing to identify conjunctival epithelial cells and in vivo imaging modality to detect the microscopic changes in this disease. Two new markers, keratin 13 and 7, have been shown that they are new biomarkers for conjunctival epithelium, as shown here. They are not expressed in the cornea at all, but in contrast, in the limbal region and conjunctiva, they're highly expressed. And these two markers have been validated in the patient specimen. Interestingly, 6 out of the 10 cases that confirmed to have stem cell deficiency, they are negative for the Goblet cell marker, again demonstrating that using Goblet cells alone, the sensitivity of identifying or detecting stem cell deficiency is low. In vivo imaging, particularly in vivo confocal microscopy, is pretty powerful imaging technique to detect or to illustrate the microstructure in the cornea, from epithelial layer to the subbasal nerve plexus, and the junction between the cornea and conjunctiva can be shown here. In total stem cell deficiency, those normal structures you've seen in the normal eye, for example, the basal cell, subbasal nerve plexus, and limbal structure are all absent in the total stem cell deficiency eye. And even in the early stage, their microscopic change had already been detected, and this change become more apparent in the intermediate stage, and the normal morphology of the corneal epithelium is absent in the late stage. In the limbus, a similar picture is seen. This microscopic change can be quantified by using basal cell density, as shown in these two graphs, that the density is declined with the severity of the disease. And as well as the epithelial thinning in the more advanced stage, the thickness of the epithelium become thinner. And this is seen in central and limbus as well. And surprisingly, the subcorneal basal cell, subbasal nerve density also declined with increase of severity of the stem cell deficiency. And in the late stage or end stage, many of the eyes, the nerve cannot be detected anymore. The utility of anterior segment OCT is also being evaluated in the diagnosis of this disease. In normal cornea, you can see the epithelium can be detected, but in the cell eyes with total stem cell deficiency, these layers are absent. This is a high MAC of the picture shown here. There also increase of hyperreflectivity in the stroma. It's pretty obvious when you see this epithelial map of the eyes with sectoral stem cell deficiency. This affected area has a thinner epithelium as compared to the unaffected area, and this is the map of the normal cornea. In addition, in the affected limbus, and the thickness of the epithelium also decline. So the question is, does it matter after you've gone all these lengths to look at this testing, is it really make any difference in the clinical diagnosis? So I'll share two cases with you. This is an 85-year-old male with history of trabeculectomy, was referred to us for management of stem cell deficiency. And what he looked like? A little bit opacity in the epithelium. And this is the fluorescein staining pattern. You can see this is affected area. But this picture is really in between stem cell deficiency and some other things. So we took a OCT and you can see that this is the vertical line. You can see abrupt changes of hyperreflectivity. The affected area is become hyperreflective, and the unaffected area hyporeflective. And there's no thinning of the epithelium. So this is not really consistent with what you see in this eyes with stem cell deficiency. So we took the biopsy of the epithelium. Actually, this eye show a ocular surface squamous neoplasia. Another case I want to share with you is the 61-year female was diagnosed with bilateral total limbal stem cell deficiency by clinical exam alone, and was recommended to have limbal stem cell transplant or keratoplasty. And And the living-related keratolimbograft was recommended, and somehow she flew all the way from New York City to Los Angeles for treatment. And that's what she looked like. Clinically, in the slit lamp exam, it's opaque cornea, 4 quadrants of corneal neovascularization, but in a confocal, central cornea, there's normal corneal epithelial cells, and then except 1 quadrant of the limbus, the nasal quadrant, there were a few goblet cells, but the rest of 3 quadrants exhibit normal limboepithelial cells. So by criteria or definition and classification, this is a minimum stage 1A disease. So she would not benefit from limbostem cell transplantation. If she had undergone the allogeneic transplantation, she would have subject to systemic immunosuppression. So on the contrary, in this eye, they had exhibited total stem cell deficiency by clinical exam, and in fact, in the lower inferior limbus, normal limboepithelial cells can be detected. So the look is quite deceiving, and without the diagnostic test. When we look at the utility of confirmatory diagnostic test, and only 26% of the eyes among 4,000 of eyes that have undergone limbostem cell transplantation had actually had a confirmational laboratory testing. So the question is that moving forward, after these diagnostic testing has been developed, is it necessary to use them? Per consensus of the International Working Group of Limbostem Cell Deficiency, the conclusion is that because of the limitation of the clinical examination, a diagnostic test is recommended if available to confirm the diagnosis of limbostem cell deficiency before any surgical intervention. So the bottom line is that how do you know if your clinical diagnosis of limbostem cell deficiency is correct without a confirmatory diagnostic test? So again, hope that many of you can make it to the World Corneal Congress next year in Boston. And thank you for attention.
Thank you, Dr. Deng. Our next speaker will be Dr. Michael Belin from the United States, talking about cross-linking and scleral contact lenses, the end of keratoplasty for keratoconus.
Thank you, Bennie. So as you heard, I've been asked to talk about cross-linking and scleral contact lenses as far as is this the end of keratoplasty. And if you've noticed on the schedule, there's not a single talk on PK or DALK in this session. These are my disclosures. So again, I was asked to talk about cross-linking and scleral contact lenses where this is a cessation. I've also added a cessation of rubbing as far as an end of keratoplasty. And if we look at PK and DALK, and also this pertains to intracorneal rings, they really should represent a management failure, not a success. With proper management, few, if any, patients should really undergo any of these procedures. The biggest limitation, however, to date is this: a failure to diagnose. For those of you who are old enough, it looks like none of you are in the audience or American, this is a famous quote from a movie in 1967 of Cool Hand Luke. Our approach to keratoconus, however, is something we call in the US ass backwards. What do we mean by that? Well, if we look at our approach to disease, and you heard Bennie talk about this, our approach should really be here, prevention. But if you think about DALK, if you think about scleral lenses or intracorneal rings, it's really here. It's in the late stage. It's treating an irreversible sequela, when again, our goal should really be here. And again, as I said, our current approach is really way too late. It's an irreversible sequela of disease. So I'm going to talk more about cross-linking and cessation of rubbing, because that's really where we try to intervene at a much earlier stage. And that may represent, I don't want to call it an end to keratoplasty, but at least a major reduction in the need for keratoplasty. And again, as I said, our approach needs to change from here to here. Talk first about contact lenses, as I said, which is not really an area that I think is treating early enough, but contact lenses really are a double-edged sword. Soft contact lenses, as we know, are rarely effective. PMMA or RGP greatly improve vision, but can cause scarring and can also mask disease progression. And we see this very, very often. Our patients are referred to optometrists. They're fitted with rigid lenses. They see well, the disease progresses, and by the time they get referred back to us for other treatment, we're really at end-stage disease that then require DALK or PK. Scleral lenses, which can be highly effective, again, are treating advanced disease, which again masks progression. And the reason for that is we typically let disease progress too long. Scleral lenses, in some of these slides were courtesy Kathryn Colby, can treat advanced disease not amenable to other contact lenses. They are in multiple different zones. Each zone can be customized. They're very effective. They can treat a vast array of different pathologic conditions on the cornea. The only limitation really is the expertise of the fitting area, which are not that common, and also the expense of the lens. You've seen slides, I think Kathy showed some of these slides earlier in one of her cases, so I'll pass over it. The most common is the Boston, also called the Pros lens, but there's a limited number of centers. They are increasing in the US. I don't know their availability outside the US, but again, the fitting process is involved. You have to refer the patient to one of the fitting centers, and also tends to be fairly expensive. There are a number of other scleral lenses available both in the US and outside of the US. But again, the problem with scleral lenses is just what I said. It means that you've allowed the disease to progress to the point of irreversible vision loss. If you think about it, all patients requiring rigid lenses, whether it's a scleral lens or a PMA or an RGP, had early progressive disease at some point. We failed to diagnose disease at an earlier stage. And the reason for that is lens fitters frequently tend to hold on to their patients too long for financial reasons. Lens fitters tend not to be ophthalmologists or surgeons, and they tend to refer patients way too late. Early intervention may obviate the need for future lens fitting and avoid surgical intervention. I want to talk a little about eye rubbing. I don't know if Damien Gattinell is here, but he'll say this is de facto the cause of keratoconus. I'll be a little less definitive, but keratoconus patients have been observed or identified or stereotyped as eye rubbing. The question really is, does this lead to this? And the answer really, as opposed to being as definitive as Damien is, we really don't know. Historically, however, keratoconus patients have been known to rub their eyes. Rubbing has also been associated with ocular itching and atopic disease. Interestingly, if you take a normal patient and ask him to rub their eyes within a few minutes, they will generate histamine levels that are equal to or exceed those with atopic disease. So again, I've put here, normal volunteers have tear film histamine levels comparable to atopic individuals after only a few minutes of rubbing. So many have concluded that because atopic disease and keratoconus appear coincidentally, that there must be a cause and effect relationship, but that does not necessarily imply causation of an etiology. They may simply be linked. So again, I think the definitive answer is really unknown at this point. Which comes first, we really don't know. Itching, rubbing, keratoconus, rubbing, itching, et cetera, we really don't know, but it does behoove us all to make sure our patients limit and we treat the reasons for their eye rubbing. There is sufficient anecdotal data, however, to recommend cessation of eye rubbing, which I do in all my patients, whether they have keratoconus or not. And you also have to often elicit family members' help, because a lot of times the patients will deny, and the family members will look at me like, what, are you crazy? Of course he does. He does it all the time. So we treat atopic disease, we treat allergic disorders, we use topical agents, we use systemic agents, and often, if needed, a referral to an allergy specialist to desensitization may be helpful. It leads us really to cross-linking and when to intervene. And I want to kind of throw this out to you as a thought here. Think about how we use cross-linking now. Now let's think about some other things we do in medicine. We don't treat high blood pressure after the patient's first stroke. We don't treat diabetes only after the first episode of ketoacidosis. We don't treat high cholesterol only after the first MI. Why do we treat keratoconus only after the patient loses vision? The holy grail should be the earliest possible identification of progressive disease and treatment with a high safety profile with the goal of preserving, but really preventing vision loss. And that's not really what we're doing currently. This was not really a new concept. This was an article published by really the fathers of cross-linking back in 2009, who they concluded that earlier treatment would be more efficacious and limit some of the adverse effects. So what's the current problem? Well, current problem is that the primary caregivers, both primary care and primary eye care, lack the ability to diagnose early disease. Very few optometrists have tomographic devices, whether it's Scheimpflug or OCT. They have posterior segment OCT because it pays a lot. They don't have anterior segment. And primary eye care, as I mentioned earlier, is often not motivated to refer until end-stage disease. Additionally, many ophthalmologists lack the ability to diagnose subclinical disease. In the US, at least, most insurance carriers deny treatment for subclinical disease, and the current cross-linking protocols are not without some inherent risk. This is what we're left with, and we really have to look at a risk-benefit ratio. We have DALK and PK, which are high risk and do benefit, but I think the risk outweighs the benefit. We have epi-off cross-linking, which in the US is approved and readily available, that has risk and has definite benefit. And we have epi-on cross-linking, which at the moment has very low risk, but the benefit's still to be shown. And there's a study coming out, at least been submitted from an Italian group, that shows long-term results of epi-on with very impressive results. There are at least an ongoing study done in the US, but that answer still remains to be answered, whether epi-on offers the same type of benefit we can get, but clearly the risk is much, much lower. Remember also that post-surgical DALK patients still require lenses often for their best visual acuity, so don't view it as a way of eliminating need of a rigid contact lens. And contact lens fitting post-PK and post-DALK is often not easier than it is fitting the keratoconic patient to begin with. Probably about 25 years ago, I published a paper with a resident of mine when I was still in Washington, D.C., where we looked at our patients who were referred for penetrating keratoplasty for keratoconus, and we successfully refit them with 70% of those patients with a rigid contact lens. So in conclusion, keratoplasty for keratoconus represents a management failure in my mind. Few, if any, patients should require keratoplasty if appropriately diagnosed early, and the biggest limitation is a failure to diagnose at the earliest stage. And just, everyone else showed you World Cornea. I'll show you this meeting coming up later this year. It's the International Cross-Linking Meeting in Zurich. Thank you.
All right, thank you. So next we'll hear from Luigi Fontana on interface keratitis after lamellar keratoplasty, how to prevent and treat.
Thank you very much. Right. I don't have any financial interest to disclose. The management of infectious keratitis following penetrating keratoplasty is a real issue for every corneal surgeon. And the sources of this infection are listed here. And among them, the donor cornea is a source of infection. Now, following a penetrating keratoplasty, the issue is that the infection of the cornea can actually rapidly progress to the anterior chamber and from then cause endophthalmitis. Following the development of lamellar keratoplasty, both anterior and posterior, we started to see new forms of post-keratoplasty infection, and this is quite representative of one of them. What is all this? It's an interface infectious keratitis, otherwise called IIK. II means we got a problem, okay? And is a form of a novel type of infection, which is a rather rare complication that could happen after DLK or EK, and oftentimes is caused by Candida. And the frequency, which is 0.02%, seems to be slightly higher than the one following penetrating keratoplasty. So the question is, are we facing a new epidemic? Are we facing an epidemic problem? Or is just a result of an over-reporting issue that comes from the literature? And this is a question that Tony Aldave posed a while ago. And we don't have an answer yet, but certainly this type of infection is slowly developing, and the average of onset is 30 days after surgery, and is fairly repetitive. So after more or less 30 days, a month after surgery, you may start seeing some spots appearing in the center of the cornea, right in the interface, in the visual space between the donor and the host. The patient is totally asymptomatic.
and there might be some multiple whitish spots in the center, or rather in the paracentral area. The anterior chamber is quiet, and oftentimes the cornea surgeon thinks that it could be a rejection or it could be a downgrowth, but it's nothing like that. It's actually an infection taking place. After some times, while you actually start, keep on thinking of what it could be, the situation gets worse, and these white spots enlarge, and you may start seeing some ocular redness, coalescence of the infiltrates, corneal edema, anterior chamber activity, and the patient starts having pain and photophobia. And the trouble is that the diagnosis is difficult because you cannot reach this area because it's right trapped between the descending membrane and the stroma. And so it's difficult to conduct microbiological tests, and you may use in vivo confocal microscopy to try to determine what's going on, but oftentimes, the answer is not there in your hands. So you need to try to think of what it could be, and oftentimes some issues can actually come from the culture of the donor rim. After DLK, the major responsible is Candida, but that could be also caused by other issues. And again, after EK, the major responsible again is Candida, but also there are other forms described in the literature. Now, oftentimes the cause is determined by the donor, and the donor is the source of the infection, the source of the transmission of this infection from the donor to the host. And this was demonstrated by the high correspondence between the donor and the host cultures. Candida is one that has the highest correspondence. And so the donor culture rim has to be reevaluated in terms of what is actually the value of is meaning. And particularly because the positivity comes only after 5 days from surgery. So you may have a chance to pre-diagnose or diagnose early what's going on the patient. Now, we try to review what is the treatment for these cases. And basically, medical treatment, topical treatment doesn't work. Systemic treatment doesn't work. Parasurgical treatment with intracameral injections or intrastomal injection may work. Surgical treatment is certainly the only one that can eradicate this type of infection. Intrastomal injections were tried and demonstrated that it could work in some cases by Elmer II, and he succeeded on treating a case of Candida interface infection after DSAEK and after DMEK. I tried myself in a couple of patients, but I wasn't so lucky. What are the problems with this treatment? You may dislocate the graft because you have to inject voriconazole way deeply into the stroma, or even after a DLK, you may perforate the descending membrane, disseminating the infection into the anterior chamber. So it could be an issue. Graft exchange is something that I wouldn't recommend, particularly if the infection is very enlarged. This is because you may easily disseminate the infection inside the anterior chamber while the infection is actually trapped in the graft-host interface. Excisional PK is certainly the most resolutive one, is probably the safest. I'm afraid is also the one that sacrifices the cornea of the recipient, but certainly works in the literature in most of the cases. So this is a little treatment algorithm. If in the early onset of the disease, you may actually try to inject voriconazole deep in the stroma. If it doesn't work and the situation worsens, certainly the only restorative remedy is doing a PK, penetrating keratoplasty. Complication outcomes, of course, there are some cases of endophthalmitis reported in the literature, graft failure, cataract, and glaucoma, and cystoid macular edema. These are the most frequent complications that may actually arise. Sources of infection, donor transmission is the most frequent one. What is actually going on? Why it could be a problem arising? Because the donor profile is changing. This is something that we don't know. Because of tissue manipulation, which nowadays happens in the eye bank more than in the operating room of the surgeon. So the areas of prevention, donor preservation, cold or warm could be one of the issues in the field. Should we supplement our preservation medium with antifungals, we don't know whether it is efficacious or it could be a damage for the endothelium of the donor. There are some targeting donor risk. We have to consider that our donors tend to increase with age, and also the time of hospitalization of these donors sometimes is also increasing. And these donors probably are at more risk, higher risk of transmitting an infection to the recipient. There is a kind of virtual fight between hypothermic preservation and organ culture. Of course, hypothermic preservation does not allow, because of the short term, the running of microbiology tests, while with organ culture, we do test every single donor during the phase of preservation. And we discard about 4 to 6% of the donor cornea because they are infected. Now, what does it translate in number and risks? I conducted a little study a while ago, and on 628 consecutive rimmed cultures that were preserved with hypothermic and with warm temperature, we found a higher percentage of rims contaminated after hypothermic preservation than after warm temperature preservation. And this is something that we would have expected because we conducted tests during preservation. But look at this. The number of rims that resulted positive after warm temperature were contaminated by Candida more frequently than after cold temperature. So in a way, we were kind of selecting donor cornea, infected by Candida with high temperature, that's called warm temperature preservation. So this could be an answer that is actually suggesting that it could be a higher risk, but in reality, this doesn't seem to be the truth. In conclusion, patients with positive ring cultures, particularly with Candida, should be reviewed weekly for 3 months after surgery. The early onset of small infiltrates in the interface should consider infectious, particularly if the donor rim is culture positive. And this is something that really is very important message to pass to all the corneal surgeon. We should revalue the donor ring cultures because they may actually tell us something at an early stage, much before the onset of the infection in the patient. Intrastomal injection may be attempted in early cases, but they do not always work, and this is something that has to be considered. Excisional PK and with intracameral antimicrobials is certainly the most effective treatment. Again, welcome to Boston 2020. Thank you very much.
Thank you. Next, we'll hear from Barry Lee, Prestripped and now Preloaded DMEK. Is this the way of the future?
Bienvenue, bonjour. Merci à Bennie et Jennifer pour l'invitation. Je parle en anglais je parle français un peu. I had to do that because I had high school and French in university and high school, and I wanted to make sure I didn't waste my money completely. So, thank you. So we are now going to switch gears to talk about endothelial keratoplasty. How many in the room do DMEK surgery? How many in the room have done DMEK surgery with preloaded tissue? So just a few. So maybe we can see if we can change some opinions here. So this is pre-stripped, preloaded tissue, and is it the future for endothelial keratoplasty? These disclosures are not pertinent to this talk. You think about the keratoplasty history, actually started in Europe. 1905 was the first successful human PK in what we now think of as Austria. And things have changed a lot. From these two videos, you can see two things. One is video quality has improved a lot from 1951 to 2019. But also our ways of doing keratoplasty for Fuchs dystrophy have really changed a lot from this Castro Viejo square graft, of which he was performing in 1951, now to me doing a DMEK surgery in 2019. Things have really changed significantly. If you look at the Eye Bank Association of America trends, the statistics in 2018 were just completed. There were big changes from 1991, 40 years after that video was done, 39,000 transplants done in the US, in 1991, only 3,600 were sent internationally. Well, look at the data in 2018, what a big change. It's doubled, over doubled in the tissues provided by the US, and 9 times more tissues now are provided to international surgeons here, for many of you in the room. The trends have also seen a big drop in penetrating keratoplasty in the US. Not only has that decreased, but also endothelial keratoplasty is significantly spiking, and this has almost doubled in just the last 6 years. Same thing with the type of endothelial keratoplasty procedure that we're doing. DSAEK was really the main surgery done in the US in the late 2005 to 2010. And now DMEK is slowly gaining, or I guess not really slowly, it's really quite rapid and increasing. You see 740 cases in 2012 to over 10,000 cases now in 2018. I think we'll just see eventually what will happen in the US is we'll see penetrating keratoplasty, DMEK and DSAEK intersect at one point, and that'll probably happen in the next 2 to 3 years, where those numbers will be about the same. This paper was published by Dr. Deng, who spoke earlier today, and what she showed from this paper really was kind of what we thought, is that DMEK is really superior to DSAEK in visual recovery time, visual outcomes, and rejection rates. We thought that that was the case, but when you look at her literature review, you really can see that that truly is the case. So now, how can we help surgeons in the operating room do DMEK surgery, make it even easier? Well, the idea now is, could we potentially provide preloaded tissue for surgeons to actually increase their surgical efficiency and really not worry about the risks of damaging endothelial tissue? Preloading tissue also can allow your surgery center to not have to pay for expensive equipment, things like trypan blue, trephine blades, or even expensive artificial anterior chamber equipment. So when an eye bank can actually provide some of these tips for you, this can help in a number of different ways. So the AJO first publication is 2016. This was where DMEK tissue was loaded in an IOL cartridge. That now, Dr. Colby's paper talked about preloading this with EndoGlide, and she published on that in January of 2017. The last 2 publications are from the Lions Vision Gift in Oregon, where they've actually preloaded tissue with modified Jones tubes. And the first publication they presented was actually presenting a way for eye banks to analyze endothelial cell preservation after doing the tissue cutting process. The last paper was really looking at how healthy the cells were after they were preloaded. This is an image of what the eye bank technicians can do here in preparing tissue. You can see here an eye bank technician using a 9.5 millimeter trephination blade and then staining the tissue after the trephine with trypan blue to help delineate that trephination zone. And I think it's interesting to see how an eye bank technician really has very good surgical hands when you select the right people. You think about the Georgia Eye Bank where I practice in Georgia, we do over 2,000 corneal transplants a year. And so these technicians get very high numbers, over 1,000 done in Georgia of EK tissues. And so they really can process tissue a lot faster than we can as a surgeon and get really experienced at doing these tissue preparation techniques. So here you see that taking the tags off of the edge to make sure there's no tearing of the stripping of the endothelium. And then once all the tags are removed, they'll just take a essentially tying forceps to help peel the DMEK tissue down. So this is sort of the pre-trephination and pre-staining technique. And then they also can pre-stamp the tissue for you. If you do DMEK, you know that's sometimes tricky to know where the tissue's upside down or reversed. And so pre-marking the tissue with a letter can help you significantly in the operating room. In this case, they're using a pre-marked stamped S. There are also recent publications that have shown a smaller F stamp might even show less endothelial cell loss. This S stamp creates about 2% cell loss. An F stamp creates about 1% if it's a smaller stamp. And so those tissue marks can help out. Pre-trephination, the surgeon, you can request exactly what size of tissue you would like. Our eye bank typically will do an 8-0 trephination for the surgeons in Georgia, but you can make that whatever you would like. And then it can be preloaded into a modified Jones tube, an IOL cartridge, or if you use the Seattle bank tissue, they have sort of purchased the rights to put their tissue in what's in the goiter cannula. This is what the tissue looks like when I get it from the eye bank. Higher magnification shows the tissue's got a stopcock so it doesn't come out. We will load this with a 14 French gauge that's trephinated, and we put it on a 5 cc syringe. We take this from the eye bank solution. Again, we use Optisol GS solution at our eye bank, which is cold storage media. And this is a syringe already loaded with BSS. We take the stopcock off. And then we like to wash out the Optisol. So this is balanced salt solution, and we're just squirting it out and then replacing it with balanced salt solution until we get all the Optisol GS out of the syringe. So that's how we load it. Once the tissue is being injected, this is again the modified Jones tube. It's about a 2.6 millimeter temporal clear corneal incision. An advantage of the goiter is you can go slightly smaller. However, these Jones tubes can be made smaller as well. It just happens that ours goes through a 2.6 the way we make them now. I'm decompressing the wound so that when I come out with the Jones tube, the tissue doesn't come out. And then I'm actually putting a 10-0 nylon suture in here too. At that small of an incision, you could argue that you don't necessarily need a suture, but it does increase the risk of that tissue coming out of the wound if you don't place a suture. And this is just using a 1-1-1 slip knot to throw it closed. And a couple little gentle tapping techniques will help open the tissue. You can see this actually has an F stamp on the tissue here. And just using a Duracimer sweep technique to unfold the tissue. And so you can see from the preloading step, it does increase your surgical efficiency, that you don't have to work on the tissue yourself. So the eye bank technicians really become the first part of our surgeon help. So you really do need to have an eye bank that you trust in helping you do this using this preloaded tissue. Once the tissue is completely unfolded, we can use our air bubble to inject. And a PI was already placed with a YAG laser. So clinical results of this technique using what's called the patient-ready DMEK, which is a patented procedure patented by the Lions Vision Gift in Portland, Oregon. They've looked at their preliminary studies of 111 eyes. This was a retrospective analysis, and the rebubble rate, meaning over a third of the tissue was not adherent. That rebubble rate was 14.4%. There were no primary graft failures, and endothelial cell loss was really compatible to other published techniques of DMEK surgery at 30.9% at 6 months. So I think that study is very comparable to many of the DMEK studies that in Sophie Deng's publication on DMEK in the Academy. At the Georgia Eye Bank, we wanted to look at our results as well using this patient-ready technique from the Lions Vision Gift in Portland, Oregon. Our eyes were about 86 eyes in this study instead of 111. Rebubble rate was a little bit higher at 22.6%, but not statistically significant. We did have 4 primary graft failures, 4%. I think if you look at Sophie Deng's DMEK publication, it was around 5% on average of primary graft failure. And our endothelial cell loss was fairly comparable at 34% at 6 months. So just a few pearls for surgeons that are beginning to learn this is choose cases with a good view. Use pseudophakic patients, avoid patients with blebs or tube shunts. I think blue-eyed patients, it's easier to see the trypan compared to brown eyes, and then avoid high myopes. If you can use pre-cut tissue, it'll save you time. Donor corneas older than 65 years old or older than 60 tend to unfold easier, so be mindful of that. Try to make your surgery as close to cataract surgery as you can. Use a PI inferiorly to help you with pupillary block, and then I think SF6 gas will help with dislocations as well. So DMEK's rising in popularity, and I think the DMEK outcomes, if you decide to use this patient-ready DMEK surgery, you'll find that the outcomes are fairly similar to DMEK preparing it yourself. Thank you.
Thank you, Dr. Lee. I just want to remind the audience that we'll take questions at the end of all the speakers. We have 2 more left. Our next speaker is Dr. Jennifer Rose-Nussabumer, talking about DSAEK, DMEK, DSO. What am I supposed to do?
Good afternoon. Thank you for having me. So as was already mentioned, in the U.S., EK has really supplanted PK for the treatment of isolated endothelial disease, and DMEK is rising. However, we have been a little bit slow to adopt DMEK, and people have been concerned about the technical difficulties. So we were interested in this question: could very thin DSAEK tissue actually produce similar results to DMEK? So we did a randomized clinical trial comparing patients with isolated endothelial disease, comparing DMEK to ultra-thin DSAEK, and we mean ultra-thin, so 60 to 90 micron grafts. Our primary outcome was visual acuity at 6 months, but we looked at a lot of other things as well, and we enrolled 50 patients. This is our primary outcome here. On the x-axis, you can see the baseline visual acuity in logMAR, and on the y-axis is the 6-month visual acuity. I'll just remind you that 0 is equal to 20/20, and higher numbers are worse visual acuity. The dotted line there, anything underneath that represents an improvement in visual acuity postoperatively. So you can see there's lots of DMEK patients represented by blue dots lower on the graph there, saying that they improved, and that is exactly what we found. So at all time points, DMEK patients had about 1.5 lines better visual acuity, and we just analyzed our 24-month data, and this has continued to be true. So they have better visual acuity even out to 24 months, and this is highly statistically significant. As far as endothelial cell counts are concerned, there was some indication that DMEK patients were having a higher attrition of the endothelial cells over time in our study, but our 24-month results look like that endothelial cell loss has stabilized, and we were unable to find a difference at 24 months. In terms of adverse events, there was really no difference. The rebubble rate was slightly higher in the DMEK arm, which has been well reported. So one of the other things that we wanted to do in looking at this study was try to figure out if DMEK is better, why is it better? And we had several hypotheses going into the study. Is it because DSAEK has a stromal-stromal interface and there's haze? Is it because DMEK has less higher order aberrations? So we obtained Pentacam, which can look at both of these things in all of our patients. And this is the output from corneal densitometry. Corneal densitometry is an objective measure of opacity in the cornea. It's measured in grayscale units. 0 means that the cornea is totally clear. 100 means that the cornea is totally opaque. A normal cornea in the center has a densitometry between 17, 20, something like that. On your left side, you can see a normal cornea. On the right side, you see a quite opaque cornea from a prior corneal infection with acanthamoeba. They have scarring. And you can see that here in the anterior stroma in particular, the densitometry is almost 74. So in our DETECT study, we looked at all of our patients and found that densitometry was highly correlated with visual acuity at all time points at baseline, 6 months, and 12 months. We haven't quite looked at 24 months yet, but we assume it would be. And then we compared between arms. And here in part A here, we're looking at the anterior cornea. B is central, and C is posterior cornea. And you can see at all time points the densitometry is improving, but there is no difference between ultra-thin DSAEK and DMEK. Therefore, we really don't think that corneal opacity or stromal-stromal interface haze is making the difference between DSAEK and ultra-thin DSAEK and DMEK. So the next thing that we looked at is higher order aberrations. And as you know, the second order aberrations like sphere and cylinder are correctable by glasses, but higher order aberrations are not. And that they're important because they really reduce the clarity on the retina. They reduce the focus on the retina. So when we looked at the higher order aberrations in DMEK versus ultra-thin DSAEK, in the anterior cornea, we really saw no difference, which makes sense because we're not really changing the anterior cornea. However, in the posterior cornea, we did see a statistically significant difference between posterior corneal higher order aberrations in DMEK versus DSAEK. And what's very interesting is this lighter gray bar represents ultra-thin DSAEK, and you see that the higher order aberrations actually increase after surgery, whereas in DMEK, they actually decrease. If you look at the posterior corneal higher order aberrations, we found that actually they were highly correlated with visual acuity. And so we did publish this in Ophthalmology early this year. We really feel that this is likely to be the reason why DMEK has a better visual acuity outcome than compared with ultra-thin DSAEK. And we really feel that at this time, DMEK is the standard of care for isolated endothelial disease. There are a couple of things coming over the horizon, and I wanted to mention them today. Decimate stripping only has been around for a while. In this technique, you strip the central guttata, and then the patient's peripheral endothelium moves centrally and clears the cornea. It does work, but you have to select the right patients. They have to have Fuchs. They have to have good peripheral endothelial reserve, and they have to be patient, allowing the endothelium to grow and take some time. With the advent of Rho kinase inhibitors, this has gotten even more interesting. Rho kinase inhibitors are thought to be involved in cell migration and decreased apoptosis, and so they are thought to have a role in endothelial cell health. And the topically administered Rapazidil has been shown, in fact, to promote endothelial cell proliferation in vitro and in a primate model. And so a lot of people are really interested in this question. What about the combination of DSO plus Rapazidil? So one of my colleagues, Marion Maxey, did this study. It was a prospective randomized outcome mass clinical trial where they took patients who had Fuchs and were undergoing DSO, and they randomized them to adjuvant Rapazidil versus observation. Then they looked at vision and endothelial cell counts. And what they found was that the Rapazidil-treated patients had higher endothelial cell densities at both 6 and 12 months, and this was statistically significant. They also achieved a vision of 20/40 or better about 2 weeks faster, around 4 weeks postoperatively, compared to the non-Rapazidil-treated patients. And this graph really shows the preoperative and then 3, 6, and 12-month post-op endothelial cell density with Rapazidil-treated patients. Another interesting thing on the horizon is endothelial cell transfer. This interesting paper, which was a proof of concept paper published in the New England Journal of Medicine, took ROCK inhibitor cultured endothelial cells and injected it into the anterior chamber of patients and then positioned the patients face down, allowing those endothelial cells to kind of float down and sit on the cornea. And they reported that 10 of the 11 patients had improvement in their pachymetry, and 9 out of 11 improved their visual acuity by at least 2 lines of vision. So this is a really interesting, possibly this is the future of corneal transplant. However, we didn't have a control group, and so there was no comparison with current endothelial keratoplasty techniques. So there's a lot to still be sorted out with regard to this. So in conclusion, DMEK has superior visual acuity outcomes. There's still some question about rebubble rates and endothelial cell loss, which would be good to evaluate in larger studies. We think that DMEK really has reduced HOAs compared to ultra-thin DSAEK, and that this is likely the cause of the improved visual acuity. And outcomes of DSO may be improved with adjuvant Rapazidil, and that would reduce the lifelong risk of graft rejection and need for topical medications in some patients. And ultimately, medical therapy may be the treatment in the future for endothelial disease, but we'll have to wait and see. So thank you so much for your time.
Thank you. So now we've worked our way from the ocular surface and dry eyes all the way through the various layers of the cornea. And now our last speaker, Dr. Joe Maeda, will talk to us about cell injection and ROCK inhibitors, no more keratoplasty for endothelial dysfunction.
Great. Thank you, Benny. Thanks for the kind invitation to come to Nice. I brought the good weather from Singapore as well. So even though we've seen talks about DMEK and they really revolutionized corneal endothelial surgery, giving us better visual acuity outcomes, lower rejection rates and less glaucoma, it does require a considerable level of expertise to do the surgery, and you do need good quality endothelial tissue. And if you look at this from a global perspective, only about 1 in 70 of our needs are covered worldwide. 50% of the world have actually no access to corneas, and this is obviously compounded by an aging population and an increasing global population in numbers as well. When we think about future concepts for endothelial disease, you can basically look at 3 most common indications for endothelial surgery. These are Fuchs, Lamellar Keratoplasty, and regrafting. And then future replacements are basically divided into 2 concepts. One is what we call regenerative therapy, and one is what we call tissue engineering and cell therapy. And the reason, the applications of these 2 concepts is really dependent on whether the disease is localized, such as in early Fuchs, or is more widespread, as we see in the other 3 indications. Now, ROCK inhibitors, or ROCK pathway, is a protein serine pathway, and it's basically involved in cytoskeletal changes in the cells, cell cycle control, proliferation, and apoptosis. And there are 2 isotypes of ROCK, ROCK1 and ROCK2. And you can see from this study published by Pirelli in 2013 that even though they're ubiquitously expressed in lots of tissues in the cornea, ROCK1 is more expressed in the corneal endothelium compared to ROCK2. Our current endothelial cells, as we know in the cornea, are stuck in what we call G1 phase, and this is due to several factors such as contact inhibition, TGF-beta2 in the aqueous, and they express negative regulators of cell cycle, so they don't basically naturally proliferate. And Professor Kinoshita's group and Professor Kozumi's group in Kyoto were the first people to really show the benefits of applying ROCK inhibitors in an animal model with corneal endothelial cells, both monkey and rabbit. And what they showed is that using ROCK inhibition, you're able to reduce the levels of P27, increase the cyclin D1, D3, and you basically allow these cells to undergo transition from G1 basically into S phase to allow these cells to basically replicate. The initial studies on human cells were slightly more conflicting compared to what we were able to see with animals. And of course, with animal studies were done on young animals, and human cells were done on a slightly older age group of donor corneas. And they showed no effect on cell viability and proliferation, but they did show an enhancement on basically wound healing, so basically cell migration. Our studies looking at donor matching actually did see a pro-proliferative effect, and you can see from this bar chart over here on the right-hand side that there is considerable donor-to-donor variation. So what this means is that some donors will proliferate basically more than others. We subsequently went on to basically show the migration effect using donor pair corneas. What we were able to show was that if you add a ROCK inhibitor into basically your donor culture rim tissue to understand cell migration, you can negate the effects of basically reduction in migration speed with aging. And what we're able to show is like a 70-year-old donor, we were able to increase the migration speed from 10% up to about 80%. Now, when we think about ROCK inhibitors, then there are 2 roles that are going to play in our future concepts. One is in basic tissue engineering, and one is in the regenerative therapy. And they've been shown to have an effect on cell expansion with human corneal endothelial cell protocols, a reduction in cell apoptosis with respect to cell delivery, an improvement in cell adhesion with respect to cell delivery, and an increase in cell migration. So I'm just going to talk about these last 2 bits for the last minutes of my talk. So let's look at tissue engineering and where ROCK inhibitors have a role in this. The 2 clinical protocols that have reached clinical trial situations for human corneal endothelial cell culture are the system in Singapore and obviously the system in Kyoto in Japan. And both of these systems use ROCK inhibitors in the culture media in order to basically increase the proliferation of our cells. How many cells can you get? You can get about 240-fold expansion, so that will allow one donor cornea to make 90 constructs if you're looking at 90 millimeters, which is approximately 3,000 cells per millimeter squared with respect to a concentration. When you have the cells that you've cultured them, there's 2 ways of delivering them into the eye. One is simply using cell injection, where the eye is basically, you inject the cells into the anterior chamber, and this is postured basically face down. The second is putting on what we call a TEK, or tissue engineered construct, and this would be a biomaterial, or it can be basically a biological material. And of course, there are advantages and disadvantages of both systems, but obviously the novelty of an anterior chamber injection is quite appealing, since you can simply inject it inside the eye. But this will require a ROCK inhibitor during the injection to increase the cell adhesion of the endothelial cells. This is an example of 2 of our rabbits undergoing surgery. On the left-hand side, you'll see TEK. On the right-hand side over here, you'll see cell injection. So this is exactly the same as doing an ultra-thin DSAEK, where basically we load it up into the endoglide. This graft has been constructed in the laboratory, and it's put on a biological carrier in this example. On the right-hand side, we're just preparing the endothelium by removing the endothelium in the rabbit eye, and then you'll see the cell injection. The cells look green in color because they have a tracker on them, so they allow us to track the cells when we simply inject them in the eye. We're using just a 30-gauge needle, and then the rabbits are basically postured face down after the surgery. If you look at the results, this is a normal rabbit cornea at 4 weeks, and this is the control group with basically the thickness of the graft at the bottom with no cells. This is what they look like with the tissue-engineered construct at the bottom over here, and this is what the cells look like after cell injection. We recently published a paper comparing the two systems using the same cells, and then they were divided up into two. One was basically looking at cell injection at the top over here, and this is looking at tissue-engineered construct at the bottom. What you can see over here when you look at the three groups is this is the group at the bottom in the red line over here where the decimase has been kept intact. We've added in ROCK inhibitor, injected our cells. The one in the green line over here is where we removed the decimase membrane, so we did decimase stripping, then we injected our cells, and the one at the top is where we just simply injected the ROCK inhibitor. So you do really need to leave the decimase membrane behind in order to get the cells to its stick. When you look at the tissue engineering group over here at the bottom, this is the positive one at the moment with the cells, and these are the negative controls above this as well. And you can see it slightly takes longer for the tissue engineering group to clear compared to what we were seeing with the cell injection group. So, and of course, Professor Kanashida's group in Kyoto published the first series of doing cell injection in a human trial on 11 patients. This is published in New England Journal of Medicine recently last year. And you can see the outcomes over here from 4 weeks up to basically 2-year outcomes showing excellent results with respect to corneal clarity and visual acuity. So the second concept is in regenerative therapy, and these are two really surgeries, either what we call DSO or what we call decimase membrane transplant. And I'll explain to you what the differences are between these two surgeries. So the first use of ROCK inhibitor in this regenerative medicine approach was again published from Professor Kanashida's group in Kyoto, where they used transcorneal freezing on a cornea and then gave Y27632, which is an archetypal ROCK inhibitor. And they showed they were able to clear the cornea with getting good visual acuity. We published a paper back in 2016 now showing the effect of Guttae on basically cell migration and showed that really if you want to get good cell migration, you need to remove the high-density guttata at the beginning to allow the cells to migrate from the paracentral area. We subsequently also wanted to show on an in vivo model that if you strip away the central area, you could replace that central decimase membrane with an allogeneic membrane transplant, and you could replicate the speed of your cell migration during the surgery as well. And I'll show you this on the next video. So on the left-hand side, what you're seeing is a video from Greg Maloney doing decimase stripping only. On the right-hand side, you see a patient, one of my patients undergoing a decimase membrane transplant. The difference in the surgery is on the right-hand side, you'll see we're preparing a decimase membrane graft. This is an allogeneic graft. There's no endothelials on there. On the back of the cornea, this graft cornea is basically 2 or 3 weeks old, and I'm going to just transplant a pure decimase membrane. On the left-hand side, you'll see Greg basically just stripping away the central Guttae from his patient with basically Fuchs. So once the graft is prepared on the right, we just stain it exactly the same way as we do with DMEK. We peel away the central 5 millimeters, and I use a goiter injector to inject this inside the eye. And then you manipulate your tissue gently over the area of where you've done the stripping, and then I put it into place using SF6 gas. Of course, there's an inferior PI at the bottom. On the left, you'll see basically Greg just stripping away the decimase membrane. This is results from his paper here on the left-hand side. His first paper on 12 eyes, 4 of those had decimase stripping. 9 out of the 12 basically cleared, and the 2 cases that basically didn't clear, out of the 3, he gave topical rapacidil, and he showed there was an improvement in visual acuity. So far, we did 4 cases because our IRB was limited to patients less than 55 years old. This is recently lifted, out of which 3 out of the 4 have cleared. 1 I had a surgical error during the surgery. We've had good visual acuity results, and all our new cases now are getting topical repressor. We've increased our age limit now up to about 80 years old for patients undergoing this surgery. More recently, this is an updated basically study from Greg where he compared his basically no rapacidil group to rapacidil group, and what you can see is that there's an increase in the clearance time if you definitely use the ROCK inhibitor combined in this DSO study, and likewise Marion showed this paper very recently, and interestingly if you look at their clearance time, it's almost the same from 2 different centers, about 4.3 weeks in Greg's study, and in Marion's study is about 4.6 weeks. So I think adding a ROCK inhibitor to your basically surgery is vitally important if you're going to do these new regenerative therapy kind of techniques. So in conclusion, corneal transplantation for endothelial disease has dramatically changed over the last 2 decades. PK is, of course, no longer considered the gold standard. EK is the gold standard. The shift in surgery has led to better visual acuity outcomes, less complications, and less risk of rejection. DSAEK is the still most common EK technique, but DMEK rates are rising. Despite this, there is still a worldwide shortage of good quality corneal donor tissue for patients with good endothelial disease. And out of the 185,000 grafts that are performed worldwide, 50,000 patients are added to waiting lists around the world. New disruptive therapies such as regenerative medicine techniques like I've shown you and tissue engineering grafts I think offer a very promising future, and they can give us better outcomes for our patients with corneal endothelial disease. I just want to acknowledge my team in Singapore and thank you for your attention.
Thank you, Mary. That's the end of our speaker session, but at this point we can take questions from the audience. All of our speakers are here if anybody has any questions. If there are not, then we've used up all of our time. So I'd like to thank the audience for coming to our session, all of our speakers for their excellent talks. And again, on behalf of the Corneal Society, I'd like to thank the European Society of Ophthalmology for inviting us to put on the symposium. Have a great rest of your meeting.